Depression is a major problem in India. In order to deal with this enormous challenge appropriately, we have to look at the current burden, the barriers to success, and outline our proposal to solve the problem. The burden. Currently, are 1 in 25 Indians dealing with depression. This means that in total 56 million people are affected. Depression is slightly more common in urban areas, and women are more affected than men. This corresponds with the global prevalence and distribution of depression. The overall prevalence of depression in India is approximately 4%. However, a recent study amongst corporate employees showed that the prevalence can be as high as 42% in certain risk groups. Let's look at the barriers. The road to battle depression is literally long and tiring for both partners and patients. In India, it's especially hard since there are a number of barriers. Technically, the treatment costs 1,500 rupees per month, which equals 20 euros, and each dollar invested in the scaling up of depression treatment could lead to a $4 return in health and workforce. Since the treatment of depression is effective in 80% of the patient, it's surprising that it's still such a major issue. The reasons are three main problems. First of all, the availability of psychological help. Secondly, ignorance and misinformation. Last and not least, discrimination and stigma. One of the biggest causes of the mental health illness is the lack of knowledge and awareness. In a recent population survey, only 1 in 3 were able to identify the depressive symptoms as such. This means that only 12% of the people with depression actually get treated. In fact, most people don't receive adequate help, which consequently leads to a huge burden for India. Let's look at the symptoms. Due to the misinformation and cultural differences, mental health problems commonly present differently compared to the Western world. Complaints in India are often of a physical nature rather than psychological. This includes pain, lack of sleep, autonomic dysfunction, or weakness. Most seek support in their families first, where they are commonly stigmatized or discriminated against. The primary reason for consulting a physician, if at all, is then usually generalized pain somewhere in the body. Psychiatrists and mental health specialists are scarce in India. Recent estimates found 0.07 psychiatrists for 100,000 population. Thus, it's not easy for people with depression to get help in India. This shortage results in a massive treatment deficit on the one hand, but also explains why many patients seek help in their family. A way to close this treatment gap could be the incorporation of general health physicians. General health physicians and other less specialized health services are more commonly available. There are about 7 per 10,000 population. However, general physicians have indicated that they feel insecure in dealing with mentally ill patients in terms of recognition and treatment. How could the recognition of depression then be improved? We would advise a combination of education, mobilization of workforce, and use of screening programs. In order to improve the availability of more healthcare professionals, we would suggest to work with the WHO-prepared MH Gap Intervention Guide, which outlines how non-specialists can contribute in the diagnosis and management of depressed patients. But also screening with a Patient Health Questionnaire Depression Module, PHQ-9, or the Back Depression Inventory Primary Care, BDI-PC7, can help to find the 1 in 25 who is depressed and patients at risk. The global treatment for depression is based on a stepped care approach. Generally, one starts with minor interventions with little restrictions, which can then be applied in the care of almost every patient. This includes to inform and educate the patient about depression, but also to add structure and proactively help to plan activities. It is self-explanatory that this kind of intervention does not need to be executed by a highly trained psychiatrist. The second step of this stepped care approach is usually cognitive behavior therapy or an antidepressant medication such as an SSRI. If the interventions are not successful, one can either change to a different antidepressant or combine antidepressants with cognitive behavior therapy. Are these steps then applicable to India? The essential medicine list for India includes 3 antidepressants: amitriptyline, escitalopram, and fluoxetine. However, also in this context, we are facing barriers. Antidepressants are not covered by insurances. In addition to the already mentioned stigma towards depression, are antidepressants commonly regarded as not effective or as cause of addictions. Amongst other factors, this causes a low adherence of patients to medication plans. What interventions are currently delivered by what discipline? GPs and psychiatrists are currently responsible for the prescription of medication. They are also the smallest group of specialists. GPs and psychologists provide support with regards to employment, living, but also neurofeedback and biofeedback. Nurses and social workers are currently in charge of the organization and supervision of support groups. So how can this be designed more efficiently? We would advise to promote a step-down education, so specialists teach lower specialities, key skills in the detection and management of depression. In addition to the thorough implementation and adherence of a stepped care plan, we can thereby make resources available for the severe cases and address the barriers previously mentioned. This process can be regarded as a task shifting. Again, let's take a closer look. The large diversity is a challenging environment for the implementation of a nationwide program. Vikram Patel has suggested a very promising Sundar method that can be used in India for the treatment and prevention of depression. The key points include: simplify the message. In order to decrease the stigma surrounding depression, we should take away the difficult psychiatric terms and turn it into an easy and understandable message. Unpack the treatment. It needs to become easier for treatment to be delivered and to create culturally accepted interventions. Deliver the treatment. Every attempt should be made to improve the accessibility of treatment, for example, close to home, in a safe environment, or in a local community. Recruit and train available human resources from local communities to deliver intervention. A more balanced healthcare worker-patient ratio is essential to execute the other aspects of Sundar. Reallocate the SCARS mental health specialists to design and oversee training programs. Later, the training performance of certain tasks can be executed by appropriately trained non-specialist health workers rather than by the specialists themselves. The goal of task shifting in Sundar can be summarized as education and providing the support with those who need. It is important that all contributing parties are included. This means patients, families, the community, specialists and non-specialists should work together in order to shift tasks and improve the situation for patients with depression. Let's see what task shifting could look like. To treat more depressive patients in India, it is necessary that more people besides the mental health professionals can perform interventions. Therefore, lay health workers should be trained to perform tasks related to their level of education. Psychiatrists, as the specialist, should train primary healthcare physicians to perform identification, diagnosis, treatment, and a referral of complicated cases. Primary care physicians then train nurses and social workers who in turn educate the community and people around the patient. Primary care physicians train nurses and social workers to perform follow-up, education, and promote the importance of mental health. Nurses and social workers train lay health workers and the community to provide support for the caregivers and patients, ensure adherence to treatment plans, help detect mental health problems, and address the stigma surrounding depression. In this way, more people will become available to recognize, treat, and prevent depression. Fortunately, the family already plays a key role in the care of depressed patients, which makes it easier to use these existing structures to further improve management and support. Additionally, people who use mental health services can also help each other by providing support, share personal experiences, and participate in self-help and mutual aid initiatives. We developed a flowchart to guide professionals in this new stepped care treatment plan. Regardless if depressive symptoms are present or not, it is always important to raise awareness for depression and promote recognition. This means destigmatizing depression, explaining symptoms and risk factors, outlining which treatments are suitable for patients without financial resources, and emphasizing the positive prognosis if treatment is initiated. For patients who show depressive symptoms, we advise to use the user-friendly Beck's Depression Inventory to assess the severity of the disorder. Treatment is tailored to the severity of depression. It is graded into mild, moderate, and severe. In mild cases, the treatment consists of education and the providing of information. This could include adding structure and planning activities together with the patient. If the chosen intervention shows no success after 6 weeks, the patient will receive the next step of treatment until the symptoms resolve. Along the lines of international guidelines, this includes social support groups, individual counseling, cognitive behavior therapy, or antidepressant medication. The patient's personal preference or contraindications should be kept in mind. With unsuccessful treatment, the patient is receiving always the next step of the stepped care treatment plan. Only in severe or treatment-resistant cases will we suggest the referral to a psychiatrist. If the taken measures are successful and the symptoms resolve, we would advise to perform a follow-up for 1 week, which can also be performed by a Skype or phone. Follow-up is very important and will be maintained at least for 3 months to prevent a relapse.